Roslan, alumni of NS2 17 and nursing graduate and the current secretary of IMU Alumni Association for the year 2021-2022. First of all, thank you for joining us for today's event. Today is our very first health talk organized by IMU Alumni Association with the collaboration of Alumni Relation Office, IMU. Our first health talk will be conducted by none other than Dr. Sandev Singh. Now, before we start, I would like to point out our house rules for today. Please mute yourself throughout the talk. You may unmute during Q&A session. Please raise your hand using the button provided if you have any question and identify yourself. We appreciate everyone's time and we would like to end this session on time as well. Therefore, do let other participants to ask question when your question has been answered by Dr. Sandev. Those are the house rules for today. Now, without further ado, let me introduce you to Dr. Sandev. So who is Dr. Sandev? Dr. Sandev Singh is a proud alumni from the ME 102 cohort and graduated from the University of Manchester in 2007. He underwent extensive training in Liverpool and Manchester in the field of gastroenterology and hepatology before being awarded the Certificate of Completion of Specialist Training, CCST, by the General Medical Council UK. He was then appointed as a consultant gastroenterologist at Royal Preston Hospital. He returned to Malaysia in 2018 and is now a consultant gastroenterologist and hepatologist in Thomson Hospital, Kota Damansara. His area of subspecialty expertise include inflammatory bowel disease, IBD, hepatology, including advanced liver failure and advanced endoscopy, and has published widely in these areas. He is passionate about teaching, which led to the inception of this webinar. His other teaching roles include gastroenterology, postgraduate diploma tutor with the University of South Wales. He was also recently appointed an adjunct senior lecturer with Monash University, Malaysia. Dr. Sandev Singh is also our Vice President of IMU Alumni Association for the year 2021 and 2022. Outside of work, he loves spending time with his family, traveling, playing badminton, and trying out restaurants. He is very eager to get on a plane soon. So do all of us, Dr. Sandev. So Dr. Sandev, sure. Without further ado, the floor is yours.
Thank you very much, Rina, for the kind introduction. So I think we're still having more participants joining in. First of all, I'd like to welcome everyone to today's webinar, which is the first that we have hosted with the new IMU Alumni Association Committee. So very warm welcome to all of you who have joined in this afternoon. I'm truly humbled by the reception that we received, and hopefully we'll get more people coming in as the talk goes on. I'm told that we have different specialties joining in. We have doctors, nurses, students, dietitians as well. So I do hope that all of us will benefit from this talk. So let me get my talk up. Okay, so my talk has been titled IBS versus IBD, what's in the name? And the reason why I chose this topic is because this topic is a large topic. They share very similar sounding names, but in fact, they're very different conditions. So hopefully over the next 40 or 45 minutes, we'll be able to dissect these two conditions, okay? And I am from the M102 batch. Okay, so diagnosing GI symptoms can be challenging. The reason for this is because there are very few symptoms of GI conditions, less than 10, but the associated conditions are in fact very large. So that is one problem with diagnosing GI problems. And the other thing is that there may be a lack of in-depth understanding in the non-GI physician group. So that sometimes causes problems. And of course, they share very similar acronyms. But in fact, like I said before, they're very different conditions. The treatment is different. And there are also different Hello?
Yeah, I can hear you.
Sorry, can everyone hear me? Yeah.
Yeah.
Sorry. So, okay, so I'm going to start off my presentation by discussing a case history. So I've called this person AA. So this lady is 36. She's a PA in a busy office. And over the last 12 months, she has consulted various doctors for very non-specific symptoms of anxiety, headache, abdominal pain, constipation, so very varied. You're the sixth doctor and you see her, and she explains that she has abdominal discomfort and she has frequent bloating. And she also reports that she's not passing stools very frequently and finds that she has to strain. So her stools are hard and she feels relieved after she's had a good bowel movement. And she has had symptoms for about 10 years. And she's never been satisfied with the explanation that she's been given by the other doctors. So you see her. So a very important part of any GI diagnosis is to eliminate any signs and symptoms of organic disease. So this chart is from the British Society of Gastroenterology. And quite simply, they've listed a few features. So over the age of 50 years old, a short symptom history, losing weight, nighttime symptoms, any family history, if they've suddenly become anemic, if they're passing blood through the rectum, or even any antibiotic use or abdominal findings. So you go through further history with her and you realize that she does not have any alarm features. And you can see from her notes that she has had previous investigations which have been unremarkable, and therefore the history is not of any concern. So you're fairly confident that this is a functional diagnosis. Okay, for those who have just joined in, we are discussing IBS versus IBD. So I've just talked about the first case history. So I'll be moving on to the second. So the next patient is a lady called BB. So she's 30 years old. She has been experiencing altered bowel habit where she's now going to the toilet 6 times a day with looser motions. And she's also lost weight in recent months. She has, however, lost her father, which could be a confounding factor, but also that she's tried some antidiarrheal and she's not really had much success. So in her, we have noticed that she has 2 clear organic features here. The symptoms are very short and she's losing weight. So losing weight, especially unintentional, is always a worrying feature. So you do some blood tests and you realize that a platelet count is slightly above normal range, CRP borderline elevated. And because she has GI symptoms, you organize a colonoscopy, which is a camera test into the colon, and you see that she has colitis, which is inflammation of the colon. Okay, so the first lady, AA, she clearly had signs and symptoms of a functional condition. So she has been labeled as having IBS. The second case is an IBD case. So moving on, so irritable bowel syndrome is a syndrome, okay? So it's a combination of symptoms, it's not a disease. And it's a functional condition, meaning that there is problems with the function of the colon, but there are no structural changes within the colon. So it is predominantly seen in females between the age of 20 to 50. The prevalence globally is between 10 to 20%, so it's pretty high. It's a chronic, relapsing, and often lifelong disorder, unfortunately. And patients will report abdominal discomfort, bloating, and they will have change in bowel habit, and they may also notice some mucus when they pass motion. There are certain triggers for this condition. So certain diet, stress. So if they have problems with managing stress or anxiety or depression, this could trigger the symptoms. Having symptoms around menses in ladies, this could also be a trigger. There are underlying psychosomatic disorders with this condition. So anxiety, depression. We see a lot of patients also having underlying fibromyalgia, chronic fatigue syndrome. And one thing to note is that although this is a functional condition, the burden to the healthcare system is huge. I see it here in Malaysia, and I used to see a lot when I was still practicing in the UK. So this is a simple diagram to just explain the pathophysiology of IBS. The full pathophysiology is still not completely understood, but what we do know is that there is definitely an altered brain-gut interaction. So the communication between the brain and gut is altered, and the brain sends signals to the gut to tell the gut to have diarrhea, to have constipation, to have altered pain perception, which is where visceral hypersensitivity also falls into place. So that is also another possible pathophysiology. The altered gut microbiota has also been postulated as one pathophysiology. And there are others like food hypersensitivity, which I'll talk about shortly, abnormal gastrointestinal motility, which is normally controlled by the serotonin hormone. And there are others like psychosocial factors, anxiety, depression, which can also drive the symptoms of IBS. So how do we diagnose IBS? So we use the Rome-4 criteria, which is a criteria which was derived in 2016. It has gone through the phases of 1, 2, 3, 4. And finally, they decided that to diagnose IBS, you need these conditions. So recurrent abdominal pain on average, at least 1 day a week in the last 3 months, and has to be associated with any of these two conditions. So it has to be either related to the poo, related to the frequency of the stool, or the form. Okay, so any of these two. And this criteria should be fulfilled for the last 3 months, with the symptom onset being at least 6 months before the diagnosis. So moving on into subclassification. So this is extremely important. So we want to divide IBS into C, M, and D. So C is constipation, M is mixed, and D is diarrhea. And I'm sure all of you may have come across the Bristol stool chart. So it's graded from 1 to 7. So 1 is hard, solid stool, 7 is diarrhea. So the reason why we classify IBS into these 3 entities is because it helps clinicians decide how we treat our patients, okay? So for someone to have IBS-C, they need to have at least 25% of the time hard stools and less than 25% of type 6 or type 7 motions. Whereas for IBS-D, it's the other way around, okay? So it's really important. So once you've decided, okay, your patient has IBS, you think he or she has IBS, you want to do some basic blood tests. And the reason for these blood tests is to ensure you're not missing out anything sinister, okay? So you do a full blood count to ensure that the patient's not anemic, there's no signs of infection, the platelet count is normal, ESR and CRP, anything that is raised will indicate inflammation. celiac serology is really a must. Maybe not so much in Asia, but in the West, it's definitely compulsory because IBS symptoms and celiac disease symptoms are fairly similar. Thyroid function test, because hyper or hypothyroidism can lead to diarrhea or constipation, respectively. And if you have a lady who's a middle-aged lady with bloating, please make sure that you do a CA-125 because ovarian tumors can present this way as well. If you have someone with diarrhea, with a recent onset diarrhea, you should rule out an infection. So do your stool cultures. The next is this test. So fecal calprotectin. This is something that I use quite a lot. Essentially, it's just a protein which is released by the neutrophils or white cells. And this protein is resistant to bacterial degradation. It's an accurate marker of intestinal activity. And it's definitely far more sensitive than doing ESR and CRP, which can go up with any other infectious or inflammatory conditions, okay? And I use it a lot for differentiation between IBS and IBD. It's also useful to monitor IBD. Patients who are on treatment, rather than do endoscopies, which has its own risk, you do calprotectin because a serial measurement will give us an idea of how the patient's doing. And in a patient who has had treatment, is doing really well, and you want to just ensure the patient has not relapsed, then you do a calprotectin. If it's low, then you're happy that patient is doing okay. If it's raised, then you may want to do more tests and initiate treatment again. So this is a forest plot from a meta-analysis from 2010, so about a decade old now. And what they were able to show was that calprotectin was able to distinguish IBD from non-IBD conditions, okay? So the sensitivity and the specificity were fairly high, high 90s, but they also did find that the calprotectin was perhaps more useful in the adult population rather than children. We don't really know why that is, but that was one of the findings of this study. So it's safe to say that calprotectin value, calprotectin test has a high negative predictive value. So if you have someone who has a normal calprotectin, you can be fairly sure, in fact, you're probably 100% sure that that patient does not have anything serious. So if they have any GI symptoms, it's probably most likely IBS, okay? So what do you do with different calprotectin results? So first of all, if it's less than 50, you're happy. This is IBS. So you don't really need to do any colonoscopy. You can forget that. If it's more than 150, yes, you are very likely to need to do an endoscopy to rule out IBD, rule out cancer, rule out diverticulosis. So there are various reasons why calprotectin can go up, but they're limited to a few, okay? So what do you do with this group, the 50 to 150? This is a borderline group. So you want to go through the history. Have they been on any non-steroidals recently? They had any infection recently? Because all these can falsely elevate the result of the calprotectin. So what I do when this happens is I go through the history again, and if there's anything that I can eliminate, let's say I can stop the non-steroidals, I'll stop it, and then I'll repeat the calprotectin in 4 to 6 weeks' time. If it's normal, then they fall into this group. If it's raised, then you want to do the endoscopy. Okay. So the differential diagnosis of IBS is huge. It includes IBD, of course, microscopic colitis. So microscopic colitis is essentially a condition where your colon looks normal, but when you take biopsies, there are histopathological changes. So there are excess lymphocytes, the collagen in your biopsy samples may be thickened, which leads to a condition called collagenous colitis, which is, we won't be covering that. Infections can be a differential, celiac disease, thyroid issues, bile acid malabsorption, cancer, any form of pelvic floor disorders, which is the dysenergic defecation. So like we have conditions called obstructive defecation syndrome. Again, very complex issues, and non-GI conditions as well can be a differential. So endometriosis, pelvic inflammatory disease. So these are some of the examples. Okay, so you're happy that your patient has IBS. So these are the steps that you can take. Okay, I find this step extremely important. Okay, extremely important. Establishing the doctor-patient relationship. If you do this well, you have won 50% of the battle, because your patient will gain your trust when you educate your patient about IBS. So IBS is a long-term condition, but it's not life-threatening. It does not cause cancer. It does not kill you. So when you reassure your patient, your patients may not need medication. So do this well. That's my advice to everyone. Okay. Then there are dietary things that you can adopt. So increase soluble fiber, reduce your FODMAPs. FODMAP is otherwise known as fermentable oligo di monosaccharide and polyols, which is something that I'll talk about shortly. You encourage your patients to try and manage your stress, anxiety, sleep well. So these things are really important, okay? The doctor-patient relationship and lifestyle modification. Then you divide your patient to either of these groups, okay? So if it's C, constipation, the main treatment would be laxatives. If it's diarrhea, it's antidiarrheals and antispasmodics, okay? So the options of treatments here, as you can see, is huge, but I won't be going through all of them because I like to cover IBD as well, but I'll touch on a few of them, all right? So this was a meta-analysis from 10 years ago, and what they found was implementing a low FODMAP diet was somewhat useful in patients with IBS, okay? And what FODMAP does to our GI system is that it increases water secretion, increases fermentation in the colon. So when this happens, patients get bloating, patients get diarrhea. So that's the mechanism behind it. Okay. So to institute a FODMAP diet, what you need to do is, if possible, get a dietitian involved, because a dietitian will be able to go through the phases, and ideally there should be 3 phases. The first phase is where you identify what are the types of food that are triggering the symptoms. Okay. The second phase is you try try them without those certain foods for 2 to 6 weeks, and then you carefully introduce the food again, and you assess for symptoms. And so you assess the patient's symptoms. And the third step is where the dietitian helps the patient personalize the menu, because there are a lot of food like let's say this is high FODMAP, like watermelon and stuff. They all have their own nutritional values. So you don't really want your patients to miss out on all these nutrients. Okay, so for everyone who's here today, examples of low FODMAP, which is what you want to advise your patients, are things like carrots, grapes, almond milk, eggs, tofu, oats. So these are the good ones. And the high FODMAP, which is what you want your patients to try and avoid, is like onions, broccoli, cabbage, cauliflower, things like that. But I always explain to my patients, you don't have to go, moderate. You don't really have to cut it out completely unless your dietitian has advised you to do so. So next is probiotics. So probiotics gets a lot of interest because we are pretty sure that there is an involvement of the gut microbiota in the pathogenesis of IBS. Although there are not many literature out there, and it's also difficult to interpret because most of the trials that have been conducted have involved several probiotics, okay? So probiotic A claims that probiotic A is better than B. So there is problems with that. And all the trials involve combination probiotics, okay? So, and from what we know, combination probiotics seems to have some benefit. And I, in fact, do recommend probiotics to my patients because I've seen it help my patients, and it's cheap, widely available, it's good for you, so why not? Okay, so I'd like to talk about Nucleotide. So Nucleotide has been around for not too long, to be fair, and it's licensed for constipation predominant IBS. It is a guanylate cyclase agonist, so it activates the receptors for this guanylate cyclase. And when it does that, it stimulates water secretion, stimulates peristalsis, which leads to diarrhea, essentially. Yeah. So one of the most common adverse effects is diarrhea. Up to 20% of patients have that adverse effect. But the good thing is it's quick and sustained. And you can see from this chart here, this was a randomized placebo-controlled trial about 8-9 years ago. And what they found was when they used the endpoints of at least a 30% abdominal pain reduction for 6 weeks or more, or an increase in the complete spontaneous bowel movement from baseline for 6 weeks or more, they found that Nucleotide was superior to placebo, and it was all statistically significant. We use it a lot, actually. It's very effective. But patients do complain that they have diarrhea, but the diarrhea tends to subside. So I always encourage my patients to just try and persevere. Okay, Rifaximin. So Rifaximin is an antibiotic. It is a non-absorbable antibiotic. What that means is that it's poorly absorbed, so you don't have, the systemic levels are low, so patients experience less side effects. And because we think that the altered gut microbiota is involved in IBS, it's useful for diarrhea-predominant IBS. And typically, we use it for 2 weeks, but that 2-week course can be repeated if necessary. And this table here just shows that after there were 2 groups, so placebo and a 14-day antibiotic group, and they followed up the patients for 10 weeks. And what they found was that Rifaximin group, they were high percentage of patients with adequate relief. So what they meant by adequate relief is lack of abdominal pain, discomfort, bloating, and diarrhea. So tricyclic antidepressants. I quite like this drug, and it's useful for patients with the unclassified IBS, where the predominant feature is pain or discomfort. It improves the visceral and central pain by acting on the norepinephrine and dopaminergic receptors. The evidence is pretty good. There are a lot of trials. A lot of patients do report a global improvement in the symptoms with pain and diarrhea. But the doses that we use in gastroenterology are far less than doses the neurologists or the psychiatrists might use, okay? I tend to use amitriptyline. I start at about 10 milligrams or 12.5 milligrams, and I gradually up titrate to about 50 mg. I rarely need to go beyond that. But I always warn my patients of the side effects because it's an anticholinergic drug. So they can have dry mouth, dry eyes, urinary retention, constipation. So you don't want to use it in constipation predominant, or any cardiac disturbances. So the next is gut-directed psychotherapy. I mean, I don't really have much experience in this because very rarely used, and it's mainly used for the very severe IBS group patients. And these patients are generally referred to a tertiary large volume center. Okay, so gut-directed psychotherapy is essentially cognitive behavioral therapy and gut-directed hypnotherapy. So it helps patients by targeting the cognitive and affective factors that drive the symptoms for that patient, okay? So there are various techniques, so they include relaxation, alteration of pain perception, reframing of the unhelpful thoughts, and also decreasing helplessness. And it is used as an adjunct, okay? Usually patients are on medications, and you try this to see if it helps the patients any better. And most of the trials have always involved medications as well, okay? But this is only advisable for patients who are emotionally stable. So patients who have underlying mental health conditions, this is not the right treatment for them, okay? Okay, so we are done with IBS. We are moving on to inflammatory bowel disease, which is one area of interest of mine. So inflammatory bowel disease essentially means either Crohn's disease or ulcerative colitis. It is, again, a chronic condition. It relapses and remits. It can happen at any age, but rarely above the age of 70, okay? The symptoms are usually subacute or chronic. So if you have someone who has recent symptoms, like symptoms for days, then it's unlikely to be IBD. Like IBS, the pathophysiology of IBD is also complex, not completely understood, but we know there are genetic postulations. So genetic, we've seen from trials that patients with IBD who have a first-degree relative, that first-degree relative may be at a higher risk of developing IBD. Environmental influences like smoking can push up the risk of IBD. We've also seen IBD in patients who have recovered from an infection and later on developing IBD. So there's various reasons. Okay, so there are more trials. There are genetic mutations called the NOD2, which trials have shown that this is seen in patients with Crohn's disease. Okay, so there's more coming up in this section. Okay. So this is a diagram. I hope this is just some revision for all of us. So Crohn's disease, as we know, is a condition which involves anywhere from the mouth to the anus, okay? And it does this in a skip fashion. So you can see the red spots are patchy and everywhere. So skip fashion. Whereas ulcerative colitis is contiguous, symmetrical. It starts off in the rectum and gradually moves up the colon, okay? Crohn's disease is a transmural condition. So what this means, it affects all layers of the GI wall, causing fissures, cobblestoning, strictures, whereas ulcerative colitis is superficial. So they get inflammation on the top. They can develop pseudopolyps, which are like little growths. And this diagram here, you can see how Crohn's is a transmural condition, and it can form strictures. Strictures here, strictures there. They can also have abscesses and fissures, okay? Okay, so this was a study done in 2019 by the UKM group, okay? And what they found was IBD the incidence of it is rising in Malaysia. So IBD was always felt to be a Western condition, but we're seeing more of it in Malaysia. I also see them in my personal clinical practice. And in fact, one of the worst IBD cases I've ever encountered was in Malaysia. So it is probably because we're more aware of the condition. Our food, our diet has changed. So there's various reasons, but this is a nice graph to just illustrate the rising IBD cases in Malaysia. The symptoms are like IBS, but additionally, they get symptoms of organic syndrome, okay? But one thing to just note is they can get extra intestinal manifestations. So things like skin changes like erythema nodosum, pyoderma gangrenosum, eye changes, uveitis, episcleritis, scleritis. They can also have large joint problems, ankylosing spondylitis, morning stiffness, and so on. So you wouldn't get any of that in IBS. So if you think someone has IBD, you do some blood tests. I always advise stool cultures because the incidence of stool infections, enteric infections in IBD is high. So always do stool culture. If someone's presenting acutely to the emergency department, you want to do an abdominal X-ray because patients can present with emergencies like toxic megacolon. Okay, there's something that you want to pick up, and this can be supplemented by some like a CT scan to get more information about the perforation or abscesses. There's various information you can get from a CT scan. MRI scans, angiography, so small bowel MRI is useful for Crohn's disease because, as you know, Crohn's can affect anywhere in the GI system. So it is useful to look out for strictures, fistulas, again, gives us a lot of information. Endoscopy, of course, we will need to do, and plus or minus capsule endoscopy. So capsule endoscopy is a capsule that examines the small bowel. So like the MRI, but this is like a video. It's a good test. Gives us lots of visual information of the small bowel, but the one downside is that there's no therapeutic role. So we can't take biopsies, we can't do anything apart from just looking. And of course, I also use calprotectin. Okay, so we're nearing the end. So treatment. So treatment of IBD is complex, okay? We have this concept of deep remission. So we want to try and achieve deep remission in all our patients. So what I mean by that is that we want to achieve clinical remission. So lack of abdominal pain, lack of diarrhea, lack of PR bleeding. Biochemical remission, so normalizing or normal calprotectin levels, normal ESR, CRP levels, and mucosal healing is the last. So mucosal healing, you do endoscopy, you take biopsies, and you want to see the lack of any active features of IBD. You also want to get your patients back to a good quality of life. So that is also one very important treatment aim, okay? And in terms of treatment, donkey's years ago, it used to be aminosalicylate, steroids, and then immunomodulators. So immunomodulators are like things like azathioprine, methotrexate. But over the last 20 years or so, we have seen, we have seen the development of drugs like infliximab, adalimumab, or golimumab. So infliximab was probably the first to be used in IBD. It was usually used in conditions like rheumatoid arthritis and psoriasis. Okay, they're great drugs, but there are concerns about infectious complications like TB. In the long run, there are also neoplastic complications like skin cancer, lymphoma. And we also know that at least 30% of patients do lose response to whatever medications they're on. So it's important to choose your drugs wisely, okay? So this is the IBD treatment pyramid. So these are the components of this pyramid. Historically, we used to just move up. So we start with 5-ASA, steroids. So this was a step-up approach and gradually move up the pyramid as the IBD worsens, if it does. But there has been a paradigm shift in the treatment of IBD. And a lot of clinicians, researchers, top IBD people in the world are now trying to use this top-down approach. So they hit the patient hard, okay, initially. Maybe not surgery straight away, but biologics, which I'll talk about, and gradually move down if necessary. This will continue to gain more debate. Clinicians may have different views. And of course, we also have to factor in the patient, what does the patient want, okay? But there are now two approaches that we can use. So very briefly, 5-ASA drugs like mesalazine, sulfasalazine, you may have heard about. It is good for colonic changes or mucosal changes. And evidence for Crohn's disease is not great though. It's available in the oral form or topical form. So topical will be like enema, so it's inserted through the anus. One of the main adverse effects is nephrotoxicity. So patients on this drug, we do advise to monitor the renal profile at least 6 months or a year once. Steroids. So steroids are useful if the patient has a relapse or an active flare of their inflammatory bowel disease. It has oral forms, topical forms, and also intravenous forms. So intravenous forms are used for patients who are really unwell. They present to emergency department with acute severe colitis. But the problem with steroids is that it should not be used long term because of the various consequences that can arise. So, and if you prescribe steroids for at least 2 weeks or more for a patient, you must remember to give them bone protection because they are at risk of developing osteopenia and osteoporosis. Okay, so any form of calcium, vitamin D supplementation will be good. Moving on to immunomodulators. So immunomodulators is good to maintain the patient in remission. If someone has active disease, these drugs don't work because it takes time. It takes at least 8 to 12 weeks to work. So, so only for your stable patients. So there is a risk of bone marrow suppression and liver toxicity, which is why we advise patients to have their full blood count and liver function tests monitored. There's also a risk of lymphoma, especially if the patient has been on the drug for 5 years or more, and also a risk of non-melanoma skin cancers, which is why we always advise our patients to have adequate sunscreen when they're out. Methotrexate, useful for Crohn's disease. It's a subcutaneous drug, although there's oral and IM forms as well. Main thing to know is that it should not be used in someone of childbearing age because it's a teratogenic drug. And folic acid supplementation is very important. It's important because it reduces the incidence of any GI side effects because patients can have nausea. You give them folic acid once a week, 5 milligrams once a week, that helps to reduce that. It's also useful to reduce the incidence of liver toxicity. So folic acid is very important. Okay, so biologics. So biologics, this chapter, this bit about biologics is huge, okay? So I'll just try and summarize, okay? So quite simply, there's two options. There's the cytokine blockers and the integrin blockers. These drugs, the Remicade, Humira, and Simponi, they've been around for a long time, especially infliximab. I use it a lot. I used to use it far more. And it's a TNF alpha blocker. We have now got something called an interleukin blocker, which attacks the IL-12 and IL-23, so IL interleukin pathways. So this is a drug called ustekinumab, Stelara. I call it Stelara. And it's useful for patients with Crohn's disease. And this drug, Entyvio, again, treats a different pathway of the IBD cascade, and it's useful for both Crohn's and colitis. And the advantage of Entyvio is that, it's a gut selective drug. So what I mean by that is that there's no huge systemic level, systemic level of the drug. So it's useful for patients who are elderly, who have had cancer in the past, or have heart problems. So this is a great drug for these group of patients. Surgery. So unfortunately, approximately 70% of patients with Crohn's disease will end up having some form of surgery during their lifetime, and only 25% in the UC group. It depends on the nature of the IBD. Is it a penetrating disease? Do they have lots of strictures, fistulas? Are they presenting, as an elective? Is it a subacute presentation, or are they presenting to the emergency department? So it does depend on all of that. There's various types of cancer, of operations, more so in the Crohn's disease group. So surgery is indicated when there's been a poor response to medications, when they've had complications from the Crohn's disease like strictures, abscess, fistula, if they have unfortunately developed cancer, that's an indication for surgery, emergency, I mentioned before, and in the children group, any form of delayed growth in that child, if they have IBD, is an indication for surgery. So how do I decide? It's not easy, honestly. It's not easy. Often it involves discussing with colleagues. I still talk to certain colleagues to get their views. It's not easy. There's various issues that we have to consider. Of course, the severity of the IBD. Is it Crohn's? Is it ulcerative colitis? Methods of administration is important because for the biologic group, we only have one, which is a tablet form. The rest are either subcutaneous or intravenous. So the younger patient group prefer the subcutaneous administration, like Humira and Humira mainly, because they can do it at work, they can do it at home. Cost, of course, is a huge factor. Do they have any form of insurance? So that also plays a role in how I decide. And of course, the treatment they've had in the past. If they've had a certain type of treatment which falls within a certain class of drug, you may not want to go back to that class. You may want to try something else. So these are the various things that you have to consider, because you need to maximize the medications, because you want to try and avoid surgery, especially in the Crohn's group. Okay. Smoking. So if there's one thing that you will take away from today, is that you please advise your patients, especially with Crohn's disease, to stop smoking, because smoking, in many studies, papers out there, it has shown that it pushes up the risk of flare of IBD, it pushes the risk of surgery, and once you've had surgery, if you're still smoking, the recurrence, the complications from surgery, if you're still smoking, it is at least 2.5-fold higher. So do advise your patients, if you do come across any with Crohn's, to stop smoking if they're still smoking. So some important considerations in a patient with IBD. So vaccination. You want to screen your patients for hepatitis A, B, C, HIV, varicella, Epstein-Barr virus, because some of the drugs, especially the biologics that we use, they can push a risk of these infections. So get your patients to have their influenza, pneumococcal vaccination. If they've not had chickenpox, or there's no clear history of previous vaccination against varicella, get them vaccinated. Hepatitis B, get them vaccinated. These drugs also can predispose patients to active or latent TB, so get them screened for that. So you can do a chest X-ray, you can do like the quantiferon test, okay? And in any patient with IBD who has had their IBD for at least 8 years or more, there's a risk of colorectal cancer. So they will need surveillance for that. Okay, and that surveillance depends on how active their colitis or their IBD is. Okay, so surveillance could be either yearly, 3 yearly, or 5 yearly. Okay, patients with Crohn's, unfortunately, are at a higher risk of malnutrition, so get a dietitian involved early. And unfortunately, there's no cure for IBD, but we can get them to a good, healthy level, at which point there's no impact on their long-term prognosis, and they're still able to function on a daily basis. Okay, unless they have a pan-proctocolectomy for UC, there's really no cure. Okay, so this is the last slide. So IBS and IBD, they're very challenging conditions. They're very different, different outcomes, different considerations. But do be mindful of overlaps. There are patients who have IBD, but they're well controlled, but they still have symptoms. So there is a crossover. You know, some patients may have a bit of IBS, so you need to try and identify these symptoms and treat them accordingly and be mindful of overlaps. IBD especially requires a full multidisciplinary approach. And what I mean by this is by involving specialist nurses if you have any, dietitians, gastroenterologists, and of course, surgeons if necessary. Thank you very much, everyone, for listening in.
Thank you, Dr. Sandev, for your informative health talk. Now, I would like to open the session for question and answer. So anyone who have any question, do let us know by raising your hand and unmute yourself. Please. Song Wai, Dr. Ao.
All right. I'll ask the first question then. Dr. Sandev, you mentioned using like TCAs, tricyclic antidepressants, for the treatment of IBS. I'm wondering, would you recommend using SSRIs as well? Has that been tried?
Yeah, SSRIs are useful as well. Yeah, I do use like things like citalopram as well, but I don't use it much. But yeah, it's useful. It is useful, and in fact, it's in the guidelines as well. You know, British guidelines, American guidelines. And the reason why I didn't really talk much about it is because I tend to use TCAs more. Yeah.
Next question.
Did everyone hear me loud and clear?
I think they can hear you loud and clear. Any other question for Dr. Sandev before we end the session? I think that's all, Dr. Sandev.
Okay, no problem.
All right, thank you.
Thank you.
Well, we are at the end of our health talk session. Once again, thank you to all participants and Dr. Sandev for the talk. Before we end this, I would like to remind the participants to submit your feedback form that we have prepared for you by using the QR code, if you can see it right now. So your feedback is important. You can always suggest to us topics that might interest you, health topics, of course, and perhaps we might have a health talk about the topic that you suggest. Now, I would like to end this session to everyone. Have a good weekend. Stay safe. Hold on, there's Perry Tan. Do you want to, Dr. Sandev, do you want to?
Yeah.
Yeah? Okay. So we
Do I
have a
want to what, sorry?
question. There's
do we have a question?
Yeah,
Oh, okay.
we do have a question from Perry Tan. Doctor, how about smoking and UC?
So smoking and actually smoking is protective against UC actually for some reason. But you know, you wouldn't really encourage smoking in anyone. It's actually an observational, mainly observational studies that have found that patients who have recently stopped smoking, for example, and they start developing some GI symptoms, then it's highly likely that they have developed UC. Yeah. So appendicectomy and smoking, for some reason, is protective against UC. Okay. So that's a good question.
Okay. All right. All right. So to everyone, have a good weekend. Thank you again, Dr. Sandev, and
Thank
stay
you,
safe,
everyone.
stay healthy.
Thank
You can unmute yourself now and say bye, wave your hand or something like that. Yeah.
Did we tell them about the feedback form? Yeah, we did, right? Sorry. Yeah.
Yes, we did.
And do leave us with suggestions of future talks if you have any.
Yep.
And we will kindly take that into consideration.
All right.
Okay.
All right. Thank you very much. Bye-bye.
Bye, everyone. Thank you. Bye.